Welcome, everyone. Good afternoon. It's lovely to see everyone here today. I'm really delighted to welcome you all to this first seminar in our series on health inequalities, and this time focused on health inequalities in early life. So that being neonates, infants, children, and young people. My name is Vashti Berry. I am an associate professor at the University of Exeter and also a member of the Southwest Peninsula Applied Research Collaboration, or ARC. And I'm one of the leads for the Children and Young People and Maternal Services National Priority Programme. And today I have the really great honor of chairing this seminar on health inequalities in early life. It's hosted by the NIHR, so National Institute for Health and Care Research, and the applied research collaborations that are funded by NIHR. If you are new to the ARCs, the Applied Research Collaborations, this is a network. There were 15 ARCs across the country. And they support health and social care research across the country in those different regions, really by academic collaborators working with health and social care providers and policymakers to do very practically relevant and meaningful research in areas of real need. And unsurprisingly, health inequalities is one of the themes and one of the areas where there is a lot of great research going on. And so we're going to have 3 speakers today come and tell us about work that's going on in this space in early life, and really delighted that they've been able to join us. We're a full house today, and although we can't see each other in person, you'll have to trust me on that. We've had around 1,000 registrations for this seminar, so welcome everyone. We're really looking forward to connecting with you and to your questions and engagement. There is a Q&A box for you to put those questions in as the speakers are speaking, and we'll have some time after each speaker to post some questions from your contributions to them. So we've got 3 talks today, and I'll introduce you to each of those speakers in due course. They'll each speak for 10 minutes, and then we have 5 minutes of questions, and all around this theme of health inequalities in early life. So our first speaker, I'm going to welcome Associate Professor Ayorinde, who is an Associate Professor at Warwick Medical School, part of the ARC West Midlands. And Abby has expertise in health services and public health research, and a keen interest in research aimed at reducing health inequalities, particularly in women's health and maternal and child health. And she's coming to talk to us today about ethnic health inequalities in maternal and neonatal health in England. So welcome, Abby. I'm going to pass over to you, give you the floor.
Thank you very much, Professor Berry, and thank you everyone for joining today. So I'll be talking about ethnic health inequalities in maternal and neonatal health in England. So here is a brief overview of what I'll talk about today. So I'll give a brief background, talk about the role of racism, and then briefly talk about existing interventions and future directions, then conclude. So that's all the 10 minutes will allow me to do. So in terms of the background, we, at least most of us, will be aware of the fact that there is a huge gap between the Black especially and the white in terms of maternal mortality. So the recent Embrace report showed that Black women are about 4 times more likely to die in pregnancy-related causes than the white. So that is a huge difference, and that has been for a while, as you can see from this trend graph. So that shows from 2010, for example, to 2020, and you can see that the gaps have been there and it's even probably getting wider. So most of the time, there has been discussions about what could be causing these differences. Sometimes it could be thought to be because Black women are more prone to some comorbidities and different things. However, research is continuously showing that even after adjusting for various things like smoking, body mass index, and even deprivation, education, so many things, the gap is still quite wide. So here I have highlighted a recent study which was published in March 2024, showing that even after adjusting for various factors, Black women remain about 3 times more likely to die. And in terms of the neonates and fetus, so we've got stillbirth trends here as well as the neonatal mortality rates. And as you can see, the Black and the Asian are still higher than the white. So that has been going on for years as well. So often, so not going into the role of racism. So like I mentioned earlier, often it's looked into as it could be the underlying causes and all that, but increasingly it's beginning to show that there are more to it than those kind of factors. And when you look at the role of racism, for instance, it seems like the elephant in the room kind of scenario, really. Every time you talk to women and all that, they highlight issues that relate to racism, but not much has been done in terms of interventions to tackle racism. So I've got here on the left, you can see a snapshot from the visual minute we had from a project we did where women were talking about institutional racism, how they've been talked to and all that. And I'll show you in this reports by different advocacy organizations as well. I've got 3 examples here. They've asked women of their experiences, and even in some, they've also asked healthcare workers about their experiences, and women highlighted various issues, especially those relating to the issue of racism, really, or people call it different things, you know, cultural bias, ethnic disparity, ethnic discrimination, and all that. But no matter how you look at it, it stems from issues relating to their culture or their ethnicity that is causing a lot of kind of bad experience and often leading to poorer outcomes. So if you look, for example, one of the quotes I have here about a sickle cell patient who has been talking to healthcare professionals about her stitches and they just ignored her until it actually got infected and things like that. So this is just an example of many, many examples of things like that. And if you look at a lot of this evidence, you see they often relate to the attitude of maybe the healthcare professionals, maybe the use of language, racially discriminatory language, the lack of knowledge about clinical manifestation of some issues among Black people compared to the white. There is assumptions as well. You've got so many examples of assumption about pain threshold, for example. So what has been done about these ethnic disparities so far? So far, we know that there has not been much done. In fact, in 2021, the NHS Race and Health Observatory commissioned us to do a mapping exercise. So it was a scoping review that we did then and included stakeholder engagement. So time will not permit me to talk much about any methods and all, but the result is already, it was published in 2022, actually. But for that project, we had conceptual framework of how ethnicity may impact on perinatal outcomes. So we had different phases and different places where interventions could be done and the kind of things that could be amenable to intervention, which are listed here. For example, on a patient level, there are various factors like maternal lifestyle and all that. And then on provider level, you've got the quality of care and things like that. So we had that mapped through the pathway and then looked at the form of interventions that we identified from the literature. So I must say that in the space of 40 years, we only had 19 included studies. So that is all we had. So the first study was published in 1981, for example, and then up until 2022, when we did the search, there were only 19 studies. And even though a lot of them mapped into different phases of that framework, you can see the ones highlighted in red. I'm not sure if you can see it properly, but we've got things like institutional racism, interpersonal racism, laws and all that were not particularly looked into. So, and again, most of the studies were done in London. So 10 out of 19 studies were done in London. So you can see that. So we published that and it had quite a lot of media attention. So what can be done from here? I think another good step forward is when the parliamentary report came out in 2023, where we've got the parliamentary report highlighting the role of racism. So I've highlighted a quote here from that report that said, "We are concerned that the government and NHS leadership have underestimated the extent to which racism plays a role." So again, this is when the form of racism that could be contributing to the ethnic inequalities started taking more of a front line, so to say. So people started looking more into that, how is it operating in this area as well. So talking about what can we do about it, in my opinion, I feel that collaborative effort is very important. So we need to have real co-production. I know that is quite difficult in terms of making co-production a real one, making sure everyone has equal partnership, including all stakeholders at all levels. And then we also want to harness community resources. So often we, not going there as if you're helping the community, but also how can the community benefit from whatever we're doing, and then they also have things to offer. So when I work with the community, a lot of times they say, they don't want to be seen as somebody that that is only there to receive help. They also have things to offer. So let's hear from what is going on, what is good, and how can we make things better. So to conclude, it is a multi-dimensional problem, so we need a lot of different angles to look at it, including even personal level as well as interpersonal level, and racism is not to be ignored. So we need to examine that, and also we cannot throw away the interventions that are existing. We need to see how to implement them effectively. And also, I've put here that innovate, but it does not have to be complicated. Sometimes simple things go a long way. So we also need to look into that and ensure that service users are adequately represented and empowered at various levels. And thank you so much for listening.
Wonderful. Thank you, Abby. Thanks very much for that presentation. We can stop sharing, lovely, and stay on the camera with me. So thank you. Just a reminder to everyone, you can suggest some questions for any of the speakers at any point using your Q&A box, which is on that bottom panel. We've got a couple that have come in for you, Abby, so I'm going to direct a couple of those to you. So one of our attendees has said, did you look at engagement with services, for example, gestation at booking or take-up of screening?
Okay, in terms of those, the study that I highlighted, where they said none of the existing factors were associated.
I believe that's where.
Oh, right. Okay.
Yes.
Yeah. I don't think so. This was not my study. This was just a recently published study by another group, but I thought it was one that highlights the important bit of those factors not contributing so much to the differences we see. But in terms of the service use and all that, I don't think they did that in that study.
Okay, great, thank you. Another question, what do you think are the key evidence gaps around co-production to tackle racism in maternity in particular?
Oh, key evidence gaps. I think the fact that there is nothing. So to be frank, because it's not something that has been looked into, so we've got a lot of experiences. So like the reports that I highlighted. So I wouldn't say experiences, you may not need to do much about experiences anymore because there is plenty. But in terms of what can be done, how do we tackle it? How do we identify it? What do we do about it? That there's nothing on those that I'm aware of.
So lots of evidence gaps.
Yeah.
And in particular around co-production, I guess there's another connected question here from someone who's a student wanting to do some work in this space. So asking you if there's been any current research you know about shared decisions with these women and health professionals?
Shared decisions and health profession. Not in that light. So there has been some intervention looking at how do we support women through those through different stages and all that, and also interpreter services, for instance, which could be linked to shared decision making, for example. But in the grand scheme of things, there's still quite a lot of things to be done in that area, to be frank. But there are some studies, although not many. So you've got the interpreter service, for example, you've got the advocacy, where you've got somebody who supports the person that cannot speak English, for instance, and all that, but not so much about shared decision making. How do you, not in the side of ethnic inequalities. So there are shared decision in maternal space generally, but not in light of reducing ethnic inequalities.
Very interesting. There's lots of questions to choose from here, and here's another couple for you, Abby. So one of our audience members asks whether you think the recent Channel 4 Dispatches documentary, if you know of it, the Black maternity scandal, I think aired in 2021, whether you think those kinds of documentaries help raise awareness of these issues and put pressure on the government. Is that something you're aware of?
That particular documentary, I'm not sure I'm aware of that one, but there are so many things these days because of different advocacy group rising up, so to say, to kind of push, the talk of the Black maternal health issue into Parliament, into, something that could be actioned on. So I believe that would have impacted definitely.
Yeah. Is there any, this was one of my questions as well, actually, so I'm glad I'm chiming with the audience. Is there any international learning about how to reduce racial inequalities in maternity care? Is anyone doing this well, Abby?
To be frank, I think there's a lot of struggle. The comparator is America, for example, but they are struggling as well in terms of what to do and how, and also the fact that their system is quite different. For instance, the insurance system and all that. So it's really hard to compare with the NHS. But in terms of the high income countries, also many of the European countries do not record ethnicity as we do. So it's really hard to find a comparator or a role model, so to say. But there is some learnings. For example, we can see some interventions they've been doing. We can look at it and see whether it's helpful. But I think we've got quite a lot of opportunities even within us It's just about how do we implement this? How do we scale things up? How do we not just pilot something and then dump it? How do we make sure it is actually carried forward? And there is issue of funding to grapple with as well.
Thank you. Fabulous. I think we'll draw this to a close. It's clearly an area of huge need and lots of interest. There's a lot of people putting in comments and questions. So really good to have this engagement. I think there's obviously huge opportunity here as well, Abby. So thank you for sharing your work with us today. And I really hope it spurs some more engagement in this area and some more conversation. Thank you. We'll move on to talk 2. So can I welcome and introduce you to Dr. Abigail Easter. Abigail is a reader in perinatal mental health at King's College London. She's a member of the ARC South London, and her work focuses on maternal morbidity and mortality, particularly among women with mental illness, and looking at how we bridge the gap between maternity and mental health care services, with obviously a focus around reducing health inequalities. So wonderful to have you. Thank you, Abigail, and I'll pass over to you.
Wonderful, thank you very much. So I will just share my slides. So thank you for the introduction. I'm going to be focusing particularly on health inequalities related to perinatal mental health care and some of the work that we're doing within ARC South London. So just a bit of an overview of where I'm hopefully going with this talk in the next 10 minutes. So I thought I'd provide a bit of a background about the impact of perinatal mental health problems across the life course, and just highlight a few studies that we've been doing in the ARC in South London to help understand and address some of these mental health related health inequalities. And briefly just touch on the national picture and how improving access to perinatal mental health care and implementing evidence-based interventions might help close some of these gaps. So we know from the evidence there's been an increasing number of studies that are looking at the impact of perinatal mental health problems over the last decade. That around 1 in 5 women will experience a mental health problem during pregnancy or in the year after birth. So these are fairly common, and they might range from depression, anxiety, to postpartum psychosis, for example. And they have direct impacts on parent and family's well-being, as well as their parented experiences. There's also strong evidence for association with poorer pregnancy outcomes and birth outcomes, as well as long-term child and infant outcomes. So these really are something that we need to be thinking how we are providing good care for women experiencing mental health difficulties. There's also been, and I mention this really because of the impact that it had on healthcare policy, a health economic report that highlighted the long-term health economic cost of perinatal mental health difficulties is around £8.1 billion if people aren't accessing care. And this accumulation of evidence has really led to a huge investment in perinatal services over the last 5 years. So our research within the ARC within South London, fortunately this Vashti has already given a good overview of what the ARCs are. So within South London, we're very fortunate to have a maternity and perinatal mental health theme as one of the 7 core areas of research that we're focusing on. And the overarching aim is to reduce health inequalities, to have a positive impact on the health and well-being of families, and particularly focusing on health inequalities that are related to social deprivation, ethnicity and mental illness, and obviously the intersection and interrelation between those inequalities. So we have a few studies that are ongoing, some which have been finished and completed, and I've linked to the website here because obviously I don't have time to go into all of them in detail. I'm going to focus, as I said, on some of those that are related particularly to perinatal mental health inequalities. Some of you may be familiar with this data. So this is data from the national inquiries, confidential inquiries into maternal deaths within the UK. And these have consistently highlighted that psychiatric causes are one of the leading causes of maternal deaths. and particularly those within 6 weeks up to 1 year to the end of pregnancy, they've consistently shown that around 40% of the postnatal deaths are related to mental health, and in particular suicide, and drug and alcohol and domestic violence. So again, this highlights that there's a real need to be focusing on this area. One of the studies that I wanted to highlight comes from a data linkage study in South London, and this utilises data from the Elixir cohort, the Born in South London data, which is linked here, as you can see, data from the maternity healthcare records, with neonatal records, mental health care records, and also GP records within Lambeth. So we've been able to kind of look at this data to see the patterns of kind of health inequalities, but also looking at kind of access to care across both maternity and mental health. And this study looked at the pregnancies over a 10-year period in South London, and the rate of life-threatening or severe maternal morbidity complications that were occurring during pregnancy. And what we found is that compared to those without severe mental illness, women who had a severe mental illness also had a higher rate of complications that were life-threatening during pregnancy. So I think this really highlights that the maternal morbidity and maternal mortality isn't always directly related to mental health difficulties, but we also need to be thinking about physical health complications. Within the same cohort, we were also interested to look at what the access to mental health services were following health admissions for self-harm in the perinatal period. We know that self-harm is a warning sign for possible suicides in the perinatal period. And what we found was that only 27% of women who had an admission for self-harm actually had any follow-up from perinatal mental health services or any adult mental health services. So there's also poor access following self-harm. So just moving on to think about what are some of the interventions that might be put into place, and how can we improve access to perinatal mental health services. And what we found from various research and research that was conducted with City University is that there's many factors that influence whether somebody will be accessing perinatal mental health care services. And these occur at the individual, the health professional level, the interpersonal level, as well as societal level. And they're also impacted by ethnic disparities in access to perinatal mental health services. And this is a study from a few years back, but I think it really clearly highlights, you can see from the graph on the left, that actually the groups in red here had significantly lower access compared to white British women, so they were less likely to be offered an appointment. But when they looked at the rate of engagement with perinatal mental health services amongst those who were in contact, you can see that actually the rate of engagement amongst some of the groups that had less access was much higher. So really we need to be thinking about access a lot more than engagement potentially. And very briefly, just to highlight some of the reasons that there might be for this, and these are some qualitative research with women from ethnic minority groups in South East London, and they really highlighted some of the difficulties in accessing that might be related to their experiences and their family cultural influences. And in particular, something that came through very clearly was that the women in this study were often perceived to be strong, less likely to be in need of help, and therefore often dismissed, which may help understand some of the barriers to being offered appointment and accessing care. So I'm not going to go into these for too much detail. I've linked to the paper, but we did develop a series of recommendations from this research, really looking at the importance of developing cultural sensitivity, strategies, and recognising the important role of the wider and extended family in engagement with services. And really important not to underestimate some of the practical barriers, so things around language, childcare, transport and technology when appointments are being offered remotely. So just finally, I wanted to highlight a study that we're conducting at the moment as part of the national cross-ARC priority programme into children and maternity health that is led by the ARC Southwest Peninsula, and this is looking at increasing access nationally to maternal mental health services. So hopefully there'll be an opportunity to share some of the findings from this study in the future. And just finally, I wanted to kind of just touch on the importance of involving and working with local communities in addressing health inequalities. We've been doing a lot of work recently with peer researchers and researchers across the theme in South London, and really going out into communities and working with community leaders who, as this quote on the left highlights, can help really bridge the gap between researchers and removing some of those barriers to participation. So in terms of take-home messages, I really think it's important to recognise that in order to reduce inequalities that are associated with perinatal mental health problems, we need to recognise the complex interplay between physical and mental health, social complexity, as well as ethnic disparities. And we need to improve access to effective interventions, which might require some adaptation, but also multi-level strategies. As well as the importance of involving communities through authentic outreach, engagement and partnerships, which are crucial. So I'll stop there because I'm sure I'm running out of time, but just to thank acknowledge the funders and the rest of the ARC South London team.
Thank you, Abigail. Fabulous. Only a few seconds over. You're all good. And some questions are flowing in, really interesting, and so much in there. It's clear we don't always have the time to dig into the detail of these things, but perhaps some of the questions will bring some of that out. There's a couple of questions related to, I guess, what might be called demographics. So some clarification around the data you presented on the link between mental illness and mortality in the perinatal period, and a question around whether that was reflected for Black women too, or specifically, and relatedly, whether there was information about where people lived. So is there a correlation with, their kind of location and place?
Yeah, I think that really good questions. I don't think we have the data to pick it apart at that granular level in such detail, but we do know that there is an interaction between ethnicity and social complexity and the higher rates of mortality, as well as morbidity. In the study that I showed in South London, that doesn't come through in the data, but I think it's largely due to them being rare complications. So actually the numbers aren't really big enough to look in detail. So I think we need national studies really to be able to do that, but undoubtedly there will be intersections and interplay between those factors.
Yeah, really helpful. Thank you. The million-dollar question, have we got any examples of services or interventions that have been effective in this space?
So yes, so I think at different levels, I think we have very good interventions for perinatal mental health, psychological interventions, and the services that are being delivered through mother and baby units, community perinatal mental health teams have shown to be effective. I think where we're at the moment is that we need to gather more evidence around that, but also look at how they can be adapted to reducing some of the other inequalities in access to them, and also thinking about outreach into communities. So there's some very good examples of local community projects that can help improve access and engagement that are run slightly differently. So the evidence is building. I think we don't have the answer yet, but there are lots of good examples that are kind of coming through.
And I guess some of the work that you and others are doing under the Children's Health and Maternity Programme is also, even when you have an effective intervention, it's how we implement those, how we take those to scale in real world services has its challenges, doesn't it?
It does. It certainly does. Yeah, and I think we've seen that across the program, that you can have an intervention that is effective, but how can that work in different settings and with different populations? I think that's another $1 million question for us.
Absolutely. Sticking with barriers, I think. So a question here around health visitors. So health visitors play a key role in parental mental health screening and identifying risk factors. Are there barriers, do you think, to accessing the service among particular groups or communities, and how might those be addressed?
It's a really good question. And actually, I haven't done a huge amount of work with health visiting, but it is a really important service for identifying women. And yes, I don't know the answer to that one actually, but it's an important question to think about. And I'm sure there are different barriers, particularly for community visits versus hospital visits.
Yeah, one to explore further. So
Yeah.
you, to the audience member for that one, we'll pick that one up. How much do we know about the mechanisms relating to or relating perinatal mental health to physical ill health? Do we think they are similar to non-perinatal populations?
These are excellent questions.
Tricky ones, but what do you think about that one?
I think there's probably similar overlap between the physical health needs that we know have been shown for decades in those experiencing mental health problems. Things such as mechanisms such as smoking and obesity. I'm sure they do play a role. But yeah, there probably are specific ones to the perinatal period that we need to be thinking about as well. But again, it's another good question that I don't think we have the answer to.
Yeah. Goodness, loads popping up. Let me just make sure. There might be time for one more. This interesting one. So you mentioned culturally sensitive strategies, I think, Abby. So are there some key principles around what such a strategy might include?
Yeah. So one of the things we were really interested in asking women and healthcare professionals accessing, it was really around kind of having a non-judgmental and open understanding. So it didn't seem to matter whether they had specific understanding of specific cultures, but a willingness to kind of be open to understand and engage and what impact that might have. So just asking the questions, being non-judgmental, and recognizing how it might impact on access to healthcare and where that might play out. So I guess really raising awareness and being non-judgmental is the important thing.
Really helpful. Thank you. I think we're going to draw that Q&A to a close. There are lots on the Q&A that you might want to go and have a look at, Abby, while we move on to the next talk. But thank you. I think if anything, this really shows the value of this kind of exchange and conference where we get to hear the questions from those who are perhaps on the front line in practice or engaged in trying to work with families in these difficult predicaments. So really seeing the spaces where we need further research and areas where we could do some more thinking and exploring. But thank you for your presentation. That was really, really interesting.
Thank you.
Right, our third final speaker, so last but not least, as they say, is Professor Rachel Hiller. So I'll welcome her. She is a professor in child and adolescent mental health at UCL, and she leads the Child Trauma and Recovery Research Group there. She's a member of 2 ARCs, not one. She's showing us up. So she's a member of ARC West and ARC North Thames. And she's going to talk to us today about trauma-focused CBT and what helps and hinders professionals and services in delivering that. So I will pass straight to you, Rachel.
And thank you everyone that's joined us. And I have really enjoyed the 2 talks before me. I'm now going to move us forward about 10 years and think through the kind of later childhood and adolescent period, and specifically around access to best evidence mental health care for young people growing up in the care system, as well as for care experienced young people more broadly. This is a group that I won't go into a lot of detail about this today, but this is a group that experience a huge amount of inequity really across the lifespan and across all different sectors and all different experiences and opportunities. And one of that is inequity in access to best evidence mental health care. So, for example, we know that if we present professionals with identical information about young people, just identifying that the young person is in care changes professional decision making. It makes them far less likely to give an accurate mental health diagnosis. And we also know quantitatively that we see an overemphasis on attachment disorders, even if that is not the child's presenting difficulty. So a lot of challenges for us to unpack. We were really thrilled to have funding from the inequalities priority in the ARCs, but also child health and maternity, to do an implementation trial where we wanted to understand a little bit more from services perspectives why it might be challenging to deliver best evidence mental health support to young people in care, but also what are the opportunities, where is this happening really well, and how can we build on that? And this project was called the ADAPT study. So I'm very sorry, I can't, some reason is flashing up and down. So I'm very sorry if hopefully someone will just jump in if you can't see things. But anyway, on the left there, you'll see a map of where the ADAPT study sat. So the ADAPT study included 28 mental health teams across 14 geographical localities across England. So we had so much learning from just what practice looks like across the country. And we trained 24 of these teams in a treatment called cognitive therapy for PTSD. So PTSD, or complex PTSD, post-traumatic stress disorder, is a trauma-specific mental health outcome, and rates of PTSD are 12 times higher in young people in care than other young people. For reasons that are perhaps unsurprising, it's a group that have experienced incredibly high rates of trauma and adversity and a lot of challenges of growing up in the care system. Trauma-focused CBT is by far the best treatment we have for complex PTSD and PTSD. And we know from meta-analyses, that are studies that pull together all of the literature, that the treatment is as effective for young people that have experienced multiple complex traumas as it is for young people that have had one-off traumas. It's a very effective treatment, but it's very rarely used with young people in care. So we trained, as I said, these 24 teams in cognitive therapy for PTSD. That's a type of trauma-focused CBT. And the teams involved were general CAMs, targeted CAMs. So they're CAMs teams that are specifically there for children in care, as well as other outpatient CAMs that are not specific to children in care, but are specialist teams, and social care-based mental health teams. And we managed to get quite a good chunk of data from these teams, and the actual participants in this were just over 240 mental health professionals from a really wide range of professional backgrounds, which really reflects what we know about services. We collected a huge amount of qualitative and interview data, and ultimately what we found after 12 to 18 months of following these services was that just under half of services with support were able to implement this treatment, this kind of gold standard treatment to young people with PTSD, but only a quarter were able to implement it to care experienced young people specifically. So again, quite a big gap between delivering to a general group of young people and to care experienced young people specifically. So we pulled this data together in an analysis called the Consolidated Framework for Implementation Research. And by having so many services involved, we were able to look at what is it that differentiates services that can implement this treatment versus those that can't implement this treatment. And what is it specifically about getting this treatment to young people in care that is so challenging? And that's what my talk is going to focus on today. So on the screen here, you can see the kind of four main areas where we see differences in teams that implement and don't implement. One of those areas are really just assessment practices. So mental health teams across the country have very different approaches in a way that I think is incredibly concerning, actually, in terms of equity of access to mental health support, but very different approaches in assessment practices for mental health, and particularly in whether they use standardized assessment tools as part of their assessment toolkit. So it goes without saying probably that services that do not use standardized assessment tools that don't believe in mental health diagnoses or in formulations that talk about mental health diagnoses like PTSD, are generally not providing treatments for those mental health conditions. And that was a big problem across the country. But the other major kind of driver of whether a team was able to implement or not was really these kind of what we call outer level factors, how our services are commissioned, how they're set up, and the capacity within services. I'm going to go into this one in a bit more detail in a minute. And then the third major driver of whether a team implemented or not was really around the culture of the service and therapist beliefs. And obviously today I'm talking about this in relation to getting best evidence services to young people in care. But I think what you'll see is that our findings really have much wider implications for current mental health service structures. And down the bottom there, I've just flagged the complexity of young people, because this is really important, that young people in care presenting to services are often presenting with a huge amount of complexity, risk, safeguarding, not being in school, placement instability, not having a consistent caregiver. Services are having to manage such high rates of complexity in our young people in care presenting to services. I'm not going to talk about that anymore today, though, simply because it doesn't differentiate services that implement versus those that don't. Services that use the treatment are still using it with young people with very complex needs, and that's an important point for us to be thinking about. So commissioning within and between services. One of the key findings from ADAPT was that many services across England are not commissioned to provide best evidence care. And that is an absolute tragedy when we think about health inequalities. They're also often not aware of each other's commissioning practices. So when we talk about best evidence care, I'm talking about something called the NICE guidelines that some people on the webinar will know about. The NICE guidelines are a great way to capture all of the research happening, and they provide very clear recommendations and very clear kind of quality standards for what type of mental health support should be available. But most best evidence mental health support is going to be multiple individual sessions with a young person. And many services we found were just simply not set up to provide this. When we look at young people in care in particular, what we found here was that they predominantly found themselves either in the care of a social care mental health team or a children in care specific CAMS team that kind of sits halfway between social care and CAMS. And these teams are amazing. They do such amazing work, but they are predominantly commissioned to work with the network around the child. So they might only offer work to, for example, the caregiver or the social work team. They're very, very important work. We don't want that to be taken away from this network. But what it does mean is that young people in care that find themselves in these systems actually cannot access direct psychotherapy. So if they have PTSD, depression, anxiety, whatever it is, and we know these issues are all really elevated in young people in care, they would just simply not be able to access best evidence care for their needs. General CAMS was, as we'd expect, quite good at implementing trauma-focused CBT, but what we found there is that many general CAMS, often quite as a surprise to them, were seeing hardly any young people in care. So we weren't seeing onward referrals from these specialist teams, or referrals were being rejected for young people in care. And so that means they're essentially finding themselves in systems that actually just cannot meet their needs, which is something we really need to be talking about and addressing. So these are the kinds of questions that we really want services to be asking themselves. Could a child in care entering my service access an evidence-based assessment of their needs? Young people in care don't all have the same mental health needs. So if we're not doing really comprehensive assessments, we're not able to match support to need. Could a child in care in my service access a NICE recommended treatment? Do our service pathways allow flexibility? Because comorbidities are really common, and what we saw across the country is that in some services, pathways actually are really restrictive. So you either go on a neurodevelopmental pathway or a trauma pathway, but actually some of these things can coexist, and in fact very commonly coexist. And then the other key piece of this is, can I easily identify within our records where young people in care go? I was really surprised when we started this study years ago now that many NHS trusts do not collect data on how many young people in care are within their service. And that just means we have no ability to understand where they're going, what's being offered to them, and therefore it really restricts our ability to advocate for their needs. So the other major driver of services implementing versus not was really this slightly tricky conversation around the culture and therapist beliefs in teams. In terms of identity, services that did implement had a much stronger identity and shared understanding about what their role was as a mental health service. We found some services, particularly social care-based services, really struggled with whether they were a mental health service or a wellbeing service. And we also found this in specialist services as well. So a lot of discussion of we're not a mental health service, we're a holistic service, and that meant that they weren't assessing for mental health. But these things aren't separate. You know, wellbeing includes mental health. Complex formulations include looking at mental health. And so that's something that I think we also need to really be talking about. Also, very simply put, services have different buy-ins to evidence-based models. So we saw a lot of examples of really strong buy-in. Yes, we want to be providing best evidence care, and those services implemented more. But we also saw a lot of discussions across the country of kind of anti-diagnosis, what would be called labelling, and anti-evidence-based interventions, particularly CBT-based interventions, that people don't believe in them and they don't like them, despite what the evidence says. And so obviously teams that don't buy into evidence-based models of practice are less likely to implement. And again, a tricky conversation. And one thing I always say here is a child has complex PTSD, whether or not we choose to tell them that. Choosing not to tell them that actually doesn't take away their symptom profiles. So we do a real disservice to young people, and young people themselves tell us this, if we don't feel like we can talk to them about their mental health needs. And this is a quote that came out a lot in services that struggled to implement, that they often didn't offer assessments and treatments because they were worried it might blame the child for their problem. And there we've got some tricky kind of professional stigma, because really offering an intervention is an opportunity for really high quality psychoeducation, normalizing, validating experiences. It's not about the child being to blame. It's about working with the child and network to help them manage and overcome their symptoms. Also, very clearly, one of the really clear findings was that services that implement better have stronger supervision structures. So they had really supportive and strong supervision structures where they could talk about anxieties, talk about biases, and that was okay. We all have anxieties, we all have biases. Putting them on the table, having those discussions, working out ways to move forward with treatments in very complex settings led to better implementation. And buy-in from leadership and the team was really important. One or the other did not work. So we had some leaders that really wanted it to be used and teams that really didn't. But we also had some teams that really wanted it to be used, and leadership gatekeeping children in care specifically away from the intervention. So both of those levels of buy-in were really important. So from this, the key recommendations are that commissioning really needs to be reviewed and should support evidence-based practice. And that includes allowing services to offer enough sessions to young people so they can engage in high-intensity treatments. Very literally, services need to come together. So we had a lot of mental health and social care teams where the service aides had never met each other. So actually literally coming together, talking about the needs of that population, making sure there's a shared language and understanding about the roles of different services is really key and can actually happen even in our current service models. And as part of this coming together, it's really important that services are making sure they all understand where young people in care in their region could access direct mental health support. There's often what we see is services presume another service is doing it, but actually that's not the case. And then finally, providing non-judgmental spaces for services to come together and talk about their biases and be okay with anxieties and sit and make sure that they can manage that. So that's it from me today. And just to mention that we co-developed some lovely resources with care experienced young people around trauma-focused CBT and PTSD, and they're all freely available to use and share on the UK Trauma Council website. Thank you, Vashti.
Thank you, Rachel, for that really interesting talk. Loads of questions have come in. I'm very aware of time, so I'm just going to throw a couple at you before we close, if that's all right. So one that might be relevant or be a question sitting in a few people's heads. Someone's asked, what makes this particular CBT treatment the best for PTSD, and where does the kind of cost and length of treatment come into this?
Yeah, so it's trauma-focused CBT isn't the best intervention, full stop. It's a intervention for any young people. It's also the best evidence intervention for adults with PTSD or complex PTSD. And there's a huge amount of research that comes behind that. And that's all outlined in the NICE guidelines. And actually, there's a lot of meta-analytic reviews that people can look at as well around that. What we're talking about here is matching interventions to the needs of the young person. There's no one intervention that should be offered to young people in care or any young people. So it's really about that needs matching. And we do know a lot about the mechanisms as well. There's been some questions about mechanisms. So we know, for example, that the mechanisms that are targeted in this treatment are those that drive PTSD in young people in care. So it's a very high quality evidence-based intervention. The cost is another issue. And the treatment is kind of 10 to 20 sessions, one-to-one sessions. And that might sound expensive, but all the time I see young people that have been in mental health services for 2-3 years, going in and out of different treatments, being offered things that have no evidence base. And we also know that the outcomes of our failure to address the mental health of young people in care are hugely expensive. I mean, billions and billions of dollars on our economy because we're not effectively supporting this group of young people. So the treatment will have costs, but I would be very confident in saying that those costs will be far less than the current consequences and the economic consequences of what we currently do.
Very helpful. There are a lot of questions around diagnosis, which we won't touch given the time, but I think some of the stuff you've touched on already in your presentation, Rachel. One quick question from someone who works with care experienced young people up to 25 years of age, asking whether there are any plans to extend this training and research into the adult mental health services.
What was that? Sorry, Vashti?
So whether there are any plans to extend this into adult mental health services, given that care experienced young people do become adults.
Yeah, indeed, they do. And then they get all kinds of diagnostic labels. So I think better that we do it really accurately and sensitively in their child and adolescent period. Yeah, so there's some really innovative practice happening across the country, and we're developing some case series at the moment of the extension of mental health services, child mental health services into early adulthood for care leavers. That has a cost associated as well, and that is a really tricky conversation. But we know the transition for care leavers into adult services is pretty disastrous at the moment. And there is growing evidence. We've done qualitative work ourselves of care leavers reflecting on that transition and that experience. So I think for us, the next step is to make sure we're really well capturing great practice, which there does exist, so other services can try to build on that, because it's a complex picture, but there are some simple things that can be done now.
Lovely. Thank you, Rachel. Thank you for that really excellent presentation. And thank you to all our speakers today. We'll close the seminar now. There is a feedback form, so please give us your feedback. There are other seminars in this series coming, so join us for those in June and July. Thank you to the organisers and to everyone who's contributed, and thank you for your questions. And we hope to see you at future seminars. Goodbye, everyone.